Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
So today on the podcast, we have João Araújo. João Araújo is a nurse and COO at Humanitude International and an expert in healthcare quality improvement. A certified Humanitude instructor since 2010, he specializes in implementing this care methodology that enhances dignity in healthcare settings. His expertise combines clinical practice, academic research, organizational leadership. He holds a master's in healthcare management from the Royal College of Surgeons in Ireland and an MBA in social economy from the IES Social Business School, complemented by special training in psychiatry from the Harvard Medical School and geriatrics from Johns Hopkins. His work has earned multiple recognitions, including MODS Award for Innovation in Alzheimer's Care in 2020 and various social impact awards. He has published extensively in peer-reviewed journals and contributed to international healthcare conferences across the world. Beyond his operational role, João serves as vice president at Via Hominis, a non-profit social solidarity cooperative. His expertise spans healthcare training, quality management, and clinical research, with a particular focus on improving care for elderly and vulnerable populations. Welcome, João. A long introduction, but I think you deserve.
Thank you. Yeah, I'm always a bit shy about those things. Yeah, but yeah, thank you. Thank you for having me.
No, it's a pleasure. So I'm going to start with a question. I know that you work primarily with aged care, but the reason I really wanted to have you on the podcast is that first, most people diagnosed with cancer, and this is a oncology and lifestyle podcast, they're older. But also I think your work is very focused on the humanization of healthcare, which I think is useful across different settings in health. And so I'm going to start full on. And why should we take this thing of humanization of healthcare seriously and not just view it as an add-on to the current clinical practice? I'm putting you on the spot to start with.
Yeah, no, it's fine. Like, yeah, because we go way back, right? So I mean, we could be
That's
here
right.
for the whole day. But yeah. So to give you a bit of context, perhaps. I've never really fit into the setting where we were supposed to be machines. Okay, so where you're supposed to follow protocol and comply with procedure, and every KPI was productivity based. So I never really understood how come a humane healthcare setting was more concerned on meeting those kind of goals rather than meeting with the person that you had just ahead of you. So because of that, I felt that I never complied very well with the system, and I never really understood why until I found out that there's a whole misconception in healthcare where we think that because of its science based and evidence based, that we're supposed to be as flawless as possible to ensure patient safety and to ensure all that. That everything humane related, relationship related, is a soft skill, that it's optional. So many times it's thought that this is vocational, that you're either born with it or you're not, and because of that, it's also optional. If you have it, good for you. If you don't have it, that's fine too, because as long as you do your job, there's no problem with it. But I started to realize that it's not possible to be a good healthcare professional if you don't have these so-called soft skills. Because to talk about quality of care, we have to understand that quality is the difference between expectation and result, which means that if you expect a lot from me and I cannot deliver that, you're going to be unhappy about it. And it's not necessarily because I'm doing a bad job, because we have a limited science. But I do need to know that satisfaction has it's the result of the difference between expectation and result. And the results that we have in a lot of these chronic diseases, degenerative diseases, they're very limited. And because of that, many times the way that people evaluate your performance is more on the way you interact and on the way you provide the service, on the relational exchange, rather than on the procedure itself. I don't know if I'm being too technical, but if I am, please correct
It's
me.
fine. Yeah.
But because of that, I started to see that so humanization is fundamental to make sure that one, people understand that we are on a partnership, that it's not a one-sided relationship, that it's not a one-way dictatorship. That I'm not here to tell you, even though sometimes it's called as like doctor's orders and whatnot. It's not an order; it's advice at best. But this advice is only valuable if you trust me, if you believe in me, and if we can work together as partners, as friends, as someone that can take this boat to the best shore. So because of that, I felt that there's a lot to be learned about it. I was always what I would consider a nice guy, but nice guy only gets you so far, because like there's people that no matter how hard you try, you just can't get through, because they're more defensive, because they have a life history where they're more defensive about others, because they had bad experiences with human beings in general, and they just don't like to give themselves away and to trust others that easily, because people come in a place where they are more vulnerable, and human beings don't like to show their vulnerability. Anthropologically, this can be explained because of our frailty in the wild. So we don't like to expose our vulnerability. Sometimes, even though we need help, we don't look for help, we don't seek help, we refuse help, even though we need it, because we don't like to be in that position. So sometimes when people come to us, they're already in a place of hurt, of pain, where they feel that they've lost themselves, where they have no hope, they have no solution. And sometimes they transfer all this to us, care professionals. And if we don't know how to deal with this, if we don't know how to anticipate this, if we don't know how to answer the person the right way at the right time, this can lead to a lot of miscommunication. And what we see around the world is that a lot of these problems that are rising in healthcare, where people are being sued for doing a good work, it's because of misunderstanding and miscommunication. Miscommunication comes from different aspects. We think it's just because of how you talk, and it's not. It's a lot of the nonverbal, about your posture, about how you look, even your muscle tension, all these little things that you might be unaware of. Our brain is very good at picking those things up. So for us to ensure that we are very skilled at all that, at reading the person, at understanding the cues that the person is giving you, and the cues that you are giving to the person, it's fundamental to establish this positive relationship, and therefore to improve the quality of care. So
Yeah.
to wrap it up, humanization of care is not optional. It is fundamental for our job, because it's a human working with another human in a very special condition. So therefore, if we are not very capable and very professional at doing this, our results are always going to be very limited in the results that they. Yeah. Yeah.
Yeah, of course. That's super important. And I think you touched on different layers as well, like the systems, the health professionals, even the patients who come with different expectations and different needs. And I was interested because you work across so many different cultures and you've trained health professionals as well across different cultures. Um, is this a global problem, or do we have, and do we have different challenges across different cultures?
Yeah, as I told you just before we started recording, I just finished a meeting with Chile. Yeah, from Chile to Colombia to Brazil to US to Japan and South Korea, where we also work with. So sometimes we think that this is different from culture to culture, and of course cultures have different rituals in terms of relationship and in terms of what is expected in healthcare. But the PR that first of all, the healthcare science is very worldwide, very globalized by now. Most protocols, most procedures, most evidence base is available in all languages, or if not in English, where everybody can have access to that, and it's very standardized by now. The type of care you get in Japan and the type of care you're gonna get in Chile is gonna be fairly similar. Then other variables, of course, but the financial resources being one of them. But the human resource is kind of the same. Now, we know that culture has different expectations and has different rules towards human rituals and human relationships, like how you're supposed to provide the service in Japan is not how you're supposed to provide the service in Singapore or in Portugal or in Italy. But it is still provided by people. And humans as a social species, we're still part of the same species. Even though cultures are different, the species is the same. And the brain is still the same. What we start to see is that actually most of us have learned these human rituals, these relationship rituals at a very, very early age. And this is a standard across the globe. Later on, when culturalization occurs, you're starting to put a new set of rules in the society that you belong to, that you can do this, you shouldn't do that. But that doesn't mean that people don't need it or don't like it. It just tells you that sometimes to do this in public is wrong. It's so, for example, we say that in Asian society, they tell us that they're not very comfortable in looking people in the eye and giving praise, giving positive feedback. Um, but when you do that, they like it. So if you look someone in the eye and say, "I'm proud of you," of course, the brain gets triggered in the same mesolimbic dopaminergic, and the dopamine discharge happens, and we're like, "Ah, that's awesome." But it's just the culture tells, "Oh, no, no, I can't do that. That's inappropriate." So when we say that in healthcare, hey, listen, it's important to look the person in the eye and tell and give positive reinforcement. Sometimes they feel a bit awkward, but it's something that it's practicable, which means the example I say is that you do a lot of awkward things in healthcare. How many times you touch people inappropriately just part as the observation, but
Right.
on the street you would never do that. Your culture tells you that it's wrong. But in healthcare, you go and do that nonetheless. So how did you break through that awkwardness? Through experience, through practice. So it's something that if you do repeatedly, you learn and you become more fluent at it, and then you become more comfortable with it, and then you're more professional at it. So it's the same thing. It's just how we approach and how we get. So regardless of culture, we're all human. We're all in the same care setting in a way, and because of that, this is applicable everywhere we go. Even though at the beginning we have to go a bit more easy to try to see if everything is appropriate, to see because we touch with the system, like you said, the healthcare system. We touch with the law. We touch with ethics and morality, and because of that, we need to go with a bit of more caution when we start in a new country. But from our experiences, that everywhere we go, the impact is the same. Actually,
Yeah, there's like a common language across all cultures, which is like the nonverbal at least.
yeah, we have a very cute story in Japan where people learn that it's inappropriate to do all this, to look in the eye and give positive feedback, and even, God forbid, to get a hug from someone.
Yeah.
But the interesting thing is that when you get to a nursing home where you have people already with advanced stage of dementia, where the cognitive impairment kind of takes away this filter where what's right or wrong, you have people queuing for hugs. Like you have you
Right.
have these old Japanese ladies literally reaching out for a good hug, because it's as if for 80 years of their life they forbid themselves to have a good hug, but now all of a sudden it's allowed again. So
Yeah.
maybe there's hope after all to all this cognitive impairment, because then it's this innocence of life can be restored.
From that.
Like, yeah, very good.
Right. I wanted to ask you as well, because we touched on all these different layers and some similarities as well across cultures. Do you think this is a problem of society as well, in a sense that we don't like aging, we don't like disease and illness in general, and we're very uncomfortable with anything to do with death or vulnerability? Do you think there's a place to also introduce these skills in society at large?
Yeah, very, very good point. I think so. For a very economical reason, there's not enough resources for us to be overly dependent on professional caregiving. So I
Exactly.
think as a society, we need to start taking our own initiatives and become more and more competent at it. Self care is still one of the main and the best solution, really. I give this example very often, that if you have a minor disease, that you know how to manage yourself at home, you do that, and you're gonna do probably much better than if you have to go to any medical organization. And again, it's not because medical organizations don't provide a good service, it's just that the way you care for yourself is so unique that no matter how good of a professional I am, I will never be able to meet your standards of care, because your rituals, your fine tuning of self satisfaction, and not to mention that care is way more than the basic biophysiological needs. You know, like the way you entertain yourself, the way you please yourself is very unique, and I cannot replicate that no matter how hard I try. So self-care is always the best solution, and the first solution in mind. However, we do know that sometimes people don't know how to do, and because of that they recur to to healthcare professions. Now, as a society, we've been always dealing with disease and death forever. Aging, okay, we might say that it's a new thing, but we've been aging as well. Like, we just haven't reached this this
Yeah.
this age before. But nonetheless, I think it's always been a bit of a taboo. Yes, something that we're not very happy with, because we put our we see the end as the final destination, and because of the uncertainty of the what's after, this existentialist doubt that we carry with ourselves as long as time, we sometimes avoid, one, thinking about it, two, talking about it, and final, but most importantly, to make amends with it. Yes, we're all getting old. Yes, we're all gonna get sick. If we have already, no, there's no one in life that hasn't been sick, and what something we've been telling to ourselves as a little lie is that we are very capable and independent and individual and a self-made person, and you go get them and you don't need anyone, and you prove them wrong and whatnot. And but we forget that as a species, we are an interdependent species. We survived because we cooperated. We survived because we relied on one another. And now that we're becoming more interdependent, I think we're struggling with this origin of thought. So, of course, I think this is something that the society needs to come to terms with. I know that this is not a very easy talk. It's not a sexy talk like they say in marketing. You know, like if you do an ad with a baby, so cute, there's hope. If you do an ad with a person with a terminal disease, the feeling overall is not going to be, oh, I wish I was her. You know. And our brain, very curiously enough, it rejects the difference. So basically, we say that this is something that you need to be. You need to be empathetic, and as if this is something natural on us, which is not. Humans, unfortunately, still have a tendency to discriminate and to neglect the difference, and to avoid something that causes pain and causes suffering. So if I see someone on a terminal with a terminal disease, I'm not going to be very happy in interacting with that person, or I'm not going to be very willingly go there and talk to that person, because I feel that maybe that could be me, and I see myself in that position, and this person somehow illustrates the vulnerability of my own life. And I don't want to deal with that at the moment. I have other stuff to be worried with. So yeah, so all this self-knowledge, all this development, emotional development as a species needs to be done sooner rather than later, because I think we're already running behind the problem. We have been very capable of understanding acute disease and accidents and trauma, but not very capable of understanding that we're all going to be dependent and have chronic diseases, and sooner or later we're going to have something that is going to take us away for good. So this to be comfortable and to put these scenarios on top of the table and to have proper discussions on it, I think it would help us to grow as a society and as a species as well, actually.
Yeah, and I think you touched on really key points, and one of the things I see a lot in cancer patients, and I experienced that myself, is that as a cancer patient, is that some people get close to you when you're diagnosed, and some people just run away for some reason.
Mm.
And it's interesting because I actually have exactly the same view, that people just run away because they can't face their own vulnerability and mortality. It has nothing to do with you. But it's an excellent point because some people get so frustrated with that, and with good reason. But
Mm.
at the same time, it's really not about the person who is sick.
Not at all, not at all. But it's interesting because it's when the person needs the most. It's when the human being is vulnerable that we're calling for help. And as a species, we have several ways to call for attention, but the first one being verbal. And when you are avoided, you feel rejected. You feel that you don't belong. You feel that you're not important. So somehow this decreases the sense of belongingness and also self-worth. That's the word I wanted. So it reduces the sense of self-worth. And if with this low self-worth value, you tend to be more vulnerable to emotional illness, to depression, to which we know very well that has an impact on the outcome of any disease as well. So it's important for us to feel that, to know that, one, we're going to put others through a process of pain, not willingly, but it's on that moment that we need someone's support even more. So we need to be aware that, if somebody is in need, they're gonna be perhaps a bit more needy. I know it's
Yeah.
a redundance, but it's normal, okay? A bit more insecure, and we are gonna feel a bit insecure ourselves. But I think it's in this human connection that wonders happen when we put ourselves in there and we admit that we don't have any more, we cannot do any
Mm.
more, and neither can you, but maybe together we can figure this thing out. So yeah, so it's
Yeah.
this availability to the other, knowing our own limitations, that makes a positive exchange in healthcare, I feel. So it's
Yeah, and the vulnerability. Yeah, absolutely.
Yeah, I think
Uh,
this idea that healthcare professionals cannot be vulnerable and cannot be doubtful and cannot fail is the first problem we face. This causes this emotional distancing and this dehumanization of care. It's the ability to know that I'm just a human being with a set of competencies that unfortunately I went to study for, and now I'm in this position that I have to be with you, and no one is comfortable. I'm not comfortable. You're not comfortable, but let's try to make the best out of it, and let's see if we can get this to good shore. Yeah.
yeah, absolutely.
Yeah.
Couldn't agree more. Um, I was going to ask you about Humanitude because I think I really want you to expand on that. I know it's a methodology of care promoting dignity and well-being. I would love us to talk to us about the. I know you have pillars, and I think the pillars are super interesting. If you could expand on those, I would love that.
Yeah. So Humanitude is by now it's what we call a social project, which means that we have a set of services to try to improve the quality of care. So originally the project started because the authors realized that to provide good care, you have to have the person's trust, and you need to be very good at establishing a relationship with the person. And they started realizing that human beings have a lot of rituals to interact with one another. The more comfortable they are with each other, the easier it is to use these pillars. The more awkward, the more strange, the more difficult the relationship is, the more unlikely it is that we use them. So the less I like you, the less I'm going to look at you, the less I'm going to talk to you, the less I'm going to touch you. The more I like you, the more I look, the more I talk, the more I touch. So basically, these humanitude pillars that they call are fundamental to establish positive emotional connections with the person. This already has by now some neurolinguistic underpinnings, where we know that if the person has a longer gaze at the same level, eye to eye, face to face, this triggers the anterior singular part of the brain that has already is associated to the release of oxytocin, that is associated to the improvement of decision making, which is associated with the perception of pain. So it's interesting. Just with a good gaze, I can reduce the perception of pain, which is something that in our brain it still amazes us when we find this out. But so yeah, so we have these four pillars. We say the gaze, the speech, and the touch. These are relational pillars, and then we have verticality. Verticality being expressed in a biological form of standing up, walking, but in a more philosophical term on giving the person the idea of self-control and autonomy, which means they can still do for themselves, they can still decide for themselves, they still have the life within them. We see is that when babies are born, they're gazed, they're talk, they're touched in a very particular manner by their primary caregivers, and the babies start to associate these pillars with care. So if I go through my life in my adulthood, the people I look for, the people I love or I'm closer with, I'm going to use the same pillars, and I will expect these people to use the same pillars with me in the same manner, because my brain was conditioned to think that if you look at me like this, if you talk to me like this, if you touch me like this, you are my friend. If you do the opposite, my brain will be very quick at picking up that you're lying, I shouldn't trust you, you're not a good person. So when we go to healthcare, the first thing we do to healthcare professionals is to teach them how to give these cues, communicational cues, so that the person understands that they mean good. Like they come in peace, they are friends, they're trying their best to do a good job. The verticality is the tough love. All right. So like your parents would tell you, what time are you back? Have you done your homework? Like we've been pushed since we're very young age to sit up, to roll up, to give your first steps. And when this happens, there's a sense of pride and achievement. And as a species, we have this mindset of achieving something and being a bit more ambitious. Like if there's no one to push for you, then you're just gonna leave it. I give this example many times that if you have no one to impress, maybe you're not gonna put your best clothes, you're not gonna leave the house, you're not gonna even perhaps wash yourself. But if you're gonna go out, you're gonna make a show out of it. So we need each other to push for each other. So for us to be a better person, we need other people that are pushing us to be a better person. So yeah, so these pillars, the gaze, the speech, the touch, and verticality are the fundamental pillars we use on Humanitude to teach how to interact and how to mean good when you approach another person. But what we've realized is that over time is that this is not enough, because we are very procedural centered. So we had to develop other tools and other protocols to establish a more evidence-based approach. So by now we have a relational procedure that you can measure and you can monitor compliance. So I can actually score healthcare professionals on their professionalization of the relationship. So we say that a healthcare professional should have at least a 60% compliance score with the sensory capture, because less than that, it shows that this person is not interested in establishing positive relationships, or is not being professional enough. Then we started realizing that this needs to change as well. Some of the setting that is very technical centered and very little humane centered. And this, I give the example many times with pediatrics, that it took them about 30 years to revolutionize the setting, to consider that affection and care belonged in healthcare. And until then, it was only a physiological intervention adapted to the size of the child. But now it's impossible to have a setting where the mother doesn't belong, where there's no paintings on the walls, where there's not a playful and affectionate environment. However, for adults, we still think that they are not like that. That all they need is a few drugs and drink water, but it's not enough sometimes. So we do need emotional support. We do need social support, spiritual support to have the best health outcome possible. And yeah, and the healthcare setting is still very unwelcome of all this change. I tend to say that if pediatrics took about 30 years to accept this, in adults it's going to take much longer, because in kids we do understand the need of love and tenderness and affectionate care. For adults, this is still very despised. It's not part of my job. I'm not paid to do that. Still very soft. Like that's no. And still some people saying that there's no evidence about it, which we still find amazing. How is this possible to reclaim that today's day and age, where psychology and neuroscience has given us so much contribute to understand that humans are much more than just a
Yeah.
machine. but unfortunately it's still not. So Humanitude comes as a first a tool for to professionalize relationship, and by now it's something that we use to certify healthcare units around the world for their humanization of care. So we're very proud to say that we have some units around the world that have gone through the whole procedure to become standards of excellence in terms of providing a more humane care.
So where do you work? Like, give me a few countries. I know you probably don't remember.
Yeah, no,
But
I still not. Okay, so first of all, it's not just me. Let's be very honest. It's a big team by now. We're about 100 people around the world, and we are in Japan, we are in South Korea, in Singapore, in Europe, we are in Portugal, Spain, France, Italy, um, in going out to US. So we have some countries a bit more developed than others, because again, we are not very aggressive in the way we do it. We wait for the call to come. So we work with people that have already done a lot of amazing work. Like for example, yeah, when you invited us to be here, it's because you had your own path and you kind of already came across something that goes in line with what we say. We don't work with people that are not interested. I know that this sounds very arrogant, but I've had enough of that. Uh,
yeah.
we work with the people that by now I say this with no shame. We work with the best in the world. Okay, so which means that there are people that have done all they could do technically, and now they start in looking around and saying, now what? So we go to the best of the OR settings, we go to the best of the ICU settings with amazing teams that have done amazing work, and then they come to us to add a little extra. So when we work in all these countries, there's different development depending on how much effort have they put into it. Some countries more devoted than others, some country faster than others, some countries with more resources than others. And yeah, we're going everywhere that we get a call because we have this theory that if you call us, it's because you need us, right? So we're healthcare.
Probably true.
So yeah, we go sometimes a bit mindlessly, do now, think later, sometimes for the better, sometimes for the worse, but so far we've been very fortunate to meet amazing healthcare professionals. I tend to say this as well, like there's very, very good work being done around the world. Unfortunately, not all of them is known. If it's bad, it comes out on the news, but if it's good, it stays between those four walls. Sometimes healthcare professionals are still a bit shy to share the best practices because they don't want to impose, they don't want to be too arrogant. But unfortunately, because of that, there's really good care being provided around the world that we never hear of. Um, there's also the bad examples. Okay, don't get me wrong, but
Yeah.
we're not here for those. So yeah, there's hope. There's hope.
I was actually going to ask you, how are you usually received by teams that you train? Because I know there's probably some sense of the organization's calling you, but then you actually have to deal with health professionals. And I was curious to know what happens in the
Yeah,
terrain.
we're very blunt. We're very blunt. Like no agendas. Okay, so when we go in, we know for a fact that a lot of people are going to be a bit suspicious. So we have this normal distribution curve, the Gauss curve, where you have people that thank you, and they say, "Oh, thank you," because I thought that was the right thing to do, and everybody thought that I was crazy. This is a minority, and then you have a majority that is a bit like, yeah, right. Okay, like I've been here, I've been doing this, I know what works, I know what doesn't work. I've seen stuff like that before, it's all very nice, very pretty, but that's not the truth. That's not the reality. And then you have the other minority that would rather die than change anything about their practice. All right. So this is the normal distribution. You have the ones that thank you and the ones that would rather die. Those are the minority. The majority is a bit skeptical, like I was too. Don't get me wrong. Like when I first heard about Humanitude, I was having my struggles in my practice. I was struggling to identify with my role. I was struggling to get my procedures done in a fluent manner where I felt that after interacting with that person, I added any value to the life of that person, even though I did the protocol and I've done it very neatly. I felt a bit disappointed with the role that I was carrying out, and I was going back to my bosses, and I was sharing them this frustration, and the answer they would say, yeah, and that's how it is, do your best. And I was like, yeah, but I was doing my best, so I was thinking I wasn't suitable for the role that I was supposed to carry out. And when I heard about Humanitude and this little talk that we're having here, I thought, yeah, right, that's very pretty, but that's not the care I know. That's the harsh reality of care is not very forgiving, neither for healthcare professionals, neither for people receiving care. It's very institutionalized, very hostile, very cold, very industrialized, and so when I went to see it in practice, that's when I figured out, okay, maybe there's something in it that I didn't know. So when people come to the training and they are a bit skeptical, I see that as a good thing. I like critical thinking. I think as a healthcare professional you should be critical and skeptical, even because if you don't have this kind of skepticism, you'd be changing every day, because every day there's a new paper, there's a new evidence, there's a new idea. You'd go crazy after 2 weeks. But if you come with this sense of defense, I understand where you're coming from. I understand as well that whatever I'm going to say, it can hurt you as well, because if I say that you're not being humane enough, you're not being kind enough, this tends to be very personal, and this is not the idea. What we say is that no human being in this position, this is what we say, you're being thrown to the wolves. No human being thrown into an organization where it's cold and sterile and industrialized and inhumane, no human being would naturally thrive in here. And we have studies, sociological studies from Goffman from the 70s that already describes these totalitarian institutions of healthcare, that very little has been done to change that. And we're 50 years later. So we know that this is normal. So after they realize that we're not here to harm anyone, and we go into care, because this is something we do as well, is that theory is very pretty, but we're very clinical, and we're very hands-on based. So we ask to identify people that are posing more challenges for whatever reason, for the complexity of the case, for the behavior, the difficulties that they're posing to the staff. So we're going to go and provide care. We're going to interact with those people and see what can be done. So as a team, we have case discussions, and we work with those cases. So after 4 days, the results are outstanding. So because of that, the staff becomes a bit more receptive, because they realize, okay, one, these guys are not here to harm us. Two, they know what they're talking. And three, it works. So just now in the 2 or 3 weeks ago, I was working with an OR team, and they were saying, OR, how is this applicable in OR? This is no. Okay, so then in the last day, one of the staff said is that uh, we saw, we did, and then we believed. So
Right.
they, um, so first they saw me, and then they did it themselves, and I was like, okay, this works, and this is applicable. So yeah, so the reception is never the best at first day, and when I say the best, is not that it's not aggressive or any way, because as I said, we work with the best that are already quite receptive to this kind of approaches, but obviously with a little skepticism in their mind. But throughout the training, they realize that, yeah, that there's something that can be done to improve their care practice and to improve the health outcomes, that we thought sometimes there's nothing we can do. Just another little concept that I like to throw out here in the podcast is this caregiving nihilism, the idea that there's no hope, that there's nothing we can do, and this sometimes is not good, because obviously we transfer this despair to the person. So the idea of positivism approach, where there's always something to be done, even when there's nothing to be done. This comes from palliative. It's a very good
Yes.
mantra.
Yep.
Um, this should be applied in any context, in any setting, because obviously even if you had a wound and you need some stitching, there's the stitching part, but then there's the body image, there's the recovery part, that that the self-care part that needs to be worked on. So just to say that this is applicable everywhere, and we need to be capable of giving the person the hope that there's life afterwards, or even when there isn't, that doesn't mean that all is lost. Like there's.
Yep.
So yes.
Yep. I was wondering, so within this frame of intervention, you also work with informal caregivers?
Yeah, not as much because it was a strategical decision we've made. We prefer to give the informal caregiving to the teams that we work with. So we'd rather empower the staff and then let the staff train the informal caregivers. We have done some experiences in the past, but it's an ocean, and we're just a drop in the ocean. So we don't work as much as we should, perhaps, but with the thought that if we train the staff, then the staff can train the families and work with the families in a bit more sustained manner.
Yeah. Yeah, absolutely. And so you have this. I want to hear about one or two cases because I think it would be really interesting for people listening and for myself. Um, but it captured my attention that one of the sort of principles you have when you're training institutions is that you never force care, but also you don't abandon people. And I was wondering if you could expand a little bit on this because I'm sure it's challenging, and we have some concerns, or I have some concerns, at least in the oncology field, because we have more and more people coming to us and saying, I don't want to do more treatment. And many cases of health professionals just, I can't do anything else for you, and you're by yourself or with whoever takes over from here. So I'm really interested in listening your thoughts on that.
Yeah, thank you for the opportunity. This is my PhD right there. So first of all, it's my main topic of interest, if I'm honest. So first of all, care refusal is a huge problem in healthcare that many times is not even pointed out. We know that self-care is more effective, prevention is more effective, uh, but if people don't cooperate, if people don't participate in care, the effectiveness of care is very limited, if at all possible. But unfortunately, sometimes it's not registered, it's not reported, and it's not even considered as a problem, which is frightening to me. Uh, because we see some studies that in long term and in long term care, that care refusal can go up to 68, almost 70%. It's huge. So which means that a lot of resources are being wasted, from a very frail. So we need to be very humble with what I'm saying right now, because the studies are very poor, and what's published about it is still very, very poor. So, but we see that a person who refuses care, they can cost up to 170% more than a person who doesn't refuse care. Why? Because you still go, you still insist, you book more appointments, you still allocate resources and time, and in the end, the cooperation is not there, and the person doesn't engage, and the person doesn't participate in care, and the care doesn't have the success that it intended, and therefore it doesn't work. Okay, so this is a big problem we have. But when we talk about people who are not considered capable of self-interest, of defending self-interest or taking the best decision for their own interests, many times we overtake that, we bypass this consent. So I don't want to shock anyone, and I know this is a very, very sensitive topic, so I need to be very careful how I bring it up, but there's a lot of people in healthcare that are receiving care without consent. And I know this is not nice to say, but it's true, because sometimes we consider the person incompetent or ignorant to decide what's best for themselves, and therefore we provide care without necessarily displaying the whole truth. It's manipulative care, coercive care, or even forced care against the person's will. And legally, this is very, very challenging, but fortunately or unfortunately, we still have a bit of the upper hand, because I know what's best, and in life or death, I can decide for you, even when that kills you. Not every country goes like that. I know this is very, very icy waters, okay? So please bear with me. No, don't. Don't kill me. Don't kill me. But I say as well, like, I'm very honest. I'm very transparent. And if I'm lying, please correct me, okay? But this tells me as well that sometimes people either don't receive care because they refuse care. And if I respect that, I don't provide care, and I know the consequence of that, and if I don't respect that, I will force care on you. And it's not nice either. So we stand in an ethical dilemma here. What do I do? Should I help or shouldn't I help? I cannot help people that don't want to be helped. So if you don't want help, I cannot help you. But I want to help you because I know how to help you. So how can I help you? And it's in this discussion of no forced care, but no abandonment of care, that we should be having a guideline for that. My PhD, I'm dreaming big to have a guideline on what to do when people refuse care, because I know that I give these numbers for dementia, for example. In dementia, we have about 55 million people in the world, conservative numbers according to World Health Organization. If 70% of these people are refusing care, we have about 30 to 35 million people refusing care in the world every day. So if we know this, how many people got up this morning against their will? How many people took the meds against their will? How many people went for activities against their will? How many people had to eat against their will? Um, it's quite a big number. It's very, very serious. And of course, these decisions are not made ill-intended. No healthcare professional decides to perform care against the person's will thinking that this is going to harm the person. But it does have negative consequences. So what we know about the refusal of care, it compromises the quality of care. It enhances negative health outcomes like dependency, premature death, a lot of stuff. So not a good solution. But then again, if we don't do, then you can be accused of neglect. So it's this fine dance of no force, but no abandonment, which means like, I can't impose this on you, but listen, I am this person, I am this professional. How can I help you? And sometimes it's through this negotiation, and it's an art of negotiation that we don't have as healthcare professionals. I say this in sales school: if you have a 10% success rate, you're an amazing salesperson. In healthcare, 10% of success is nothing. So you have to be much, much more capable of selling the treatment and the help. However, we don't have at all any training on this. So you're supposed to be this amazing salesperson to sell one of the most difficult things, which is help, which is to sell something that sometimes is gonna cause you more pain, gonna cause you more harm. But listen, you're gonna feel better afterwards. Trust me. It's like,
Yeah.
but we are expecting the person to accept this, no questions asked. And the world has changed. The service provision has changed. People feel that they are more capable of deciding for themselves. They're more well informed. They have their rights, and this is all absolutely true. But we, as a healthcare industry, we didn't update our practices to accommodate for these changes. So right now we're in a bit of a conundrum. Like, you either force care or you're accused of neglect. Which one do you prefer? It's not an easy call, but what we're saying is that nothing authorizes us to provide forced care. But I have to be very certain that I'm not neglecting the person. That's why the no abandonment. So I need to have a lot of offers on the table. I have to say, if not this, then what? If not now, when? If not me, who? And this care negotiation is what it makes us achieve a better acceptance of care. So some of the Humanitude units, we're talking about 98% care acceptance. So which means that still 2% of people refuse care, but it's very far from the 70% that we see right now on the evidence-based published articles. So when I see these big discrepancies in results, when I see a prevalence of refusal of care 70%, and I see a 2% on the other end, what does that tell me about it? That we don't know enough to understand the phenomenon. If you have such a discrepancy of numbers, you're a very good doctor and you have a very high acceptance rate of treatment. This guy is a very good doctor and has a very low acceptance of treatment. Now, who's right? Who's wrong? I don't know. Because these are productive KPIs. Like, if you tell me, oh yeah, but my patients, they all go for treatment. It's like, yeah, maybe you're not giving them a choice. You know, On the other hand, if somebody's saying, "Oh, my patients, they always refuse treatment," yeah, maybe you're not the best salesman either, you know. So it's not necessarily true, and it's not necessarily a one-way street. But we would like to bring this to light and to bring more certainty to this ethical dilemma, because healthcare professional is based on ethical decisions. You know, it's a lot of clinical judgments, it's a lot of risk taking, but hopefully for the best. And our science comes from risk management and reducing the risks and the negative outcomes, knowing that they can still occur even under the best circumstances. But obviously, when we come to healthcare refusal, we care refusal in healthcare, we still have a lot to go through.
Yeah. And it's interesting because it brings to my mind different situations as well, because obviously we have these type of situations in which you know you can help, but the person doesn't want to be helped. But I'm thinking about situations in palliative care that we see quite often of people who have, advanced cancer still. The oncologist is still investing, still providing that fourth line of chemotherapy, and the person is so tired and they just don't want to continue.
Mm.
And we negotiate that with the person, like, should we continue, should we not continue? And what I find very interesting as well is that most conflicts or most problems in communication between patients and doctors and other clinicians is very related with values as well, like what is my value at the moment. And usually I find that doctors, because I know them best, they're very guided by, a sense of uh, prolonged survival. And sometimes patients are not there, just not anymore. It's not about survival, it's about, quality of life, it's about spending time with the people they love. And then they just pulling to each side, but actually nobody's standing that they're on different pages, which is very interesting as well.
I understand the value discussion, but it starts to be a bit funny to me by now, because WHO has defined health a long time ago as a subjective state of well-being, right?
Yeah.
Which means that it can be influenced by biological, emotional, social, spiritual factors, and we still have such a biomedical service still so focused on acute care that we're still incapable of understanding what is the best health outcome for the person. So
Yeah.
we still measure survival rates, we still measure readmissions and lengths of stay and infections. And don't get me wrong, all those things are fundamental, they're very important. That's how we got this far. But we have to start thinking of the new age of medicine, where acute disease is not our main concern anymore. You know, it's chronic
Yeah.
disease, it's degenerative disease, it's end of life. And we're still so far from adjusting our settings to those to accommodate what the person really wants and really needs. Still thinking that it's about breathing and intake and output, uh, and it's not.
Yeah.
No, it's much more than that. So you can have, I say, you can have all your blood tests perfectly fine, and you can still feel ill.
Yeah.
And therefore, it's this element of help that we're failing to achieve. I know I can help you in different ways, but unfortunately, we're not competent for that. And that's just
Yeah.
the faster we admit that, the faster we'll develop towards that problem. We're still very
Yeah.
negligent towards anything that is not biophysiological. We're still uh, very hard to admit that there's much more out there other than just plain I say the psychopharmacology because I work mostly with degenerative neurophysical diseases, but there's much more than medication out there, you know. And because of that, I say many times, how often is there's a correlation between depression and neurocognitive disorders? Very often. How many
Yeah.
times we have a psychologist in the team? Almost never. So of course, and then it's like, what are you going to do? Is like nothing. You don't know how to do. So we are incompetent, and as simple as that. It's not because we're bad care professionals. It's just that we don't have that skill. So the faster we admit that we are not there yet, the faster we'll get to get there.
Yeah.
But unfortunately, it's a very harsh discussion. Still, a lot of colleagues are not capable even to just hear it, to just never mind to talk about it. Okay,
Right.
in a mature professional manner. But that's why we stopped working with people that don't want to work with us, because otherwise we're going to be starting things that just become very offending and very, very distressful. And I think the setting is already distressful enough as it is.
That's right. Good.
We be aiming for the well-being of caregivers as well, so let's be kind to one another, and let's be understanding that there's we're doing our best every day, even if our best is not good enough.
Yes. And tell me about a few cases, because I know you have lots of stories to tell, because you have so many years of actually working with teams and working with patients. Uh, Tell me about the impact you guys had working with some of your patients.
So a flaw I have is that I can be very cognitive, and sometimes I'm not a good storyteller. And unfortunately, the bad ones are the ones that stick the most, right? But I do have a
Yeah.
couple of cases that kind of stick with me, because I realized how human vulnerability is near everyone. And I think, yeah, when you work with in healthcare, you realize that you're only a speck in the universe, and what you can do is really limited. So I've met a couple of people in the last couple of years that I really realized that they were there, they were alive, um, with a lot to live. Like, I have this story of this lady who was considered palliative case because she was for non-invasive measures, so advanced care planning. Every time she goes to the hospital, she comes a bit worse. So the family with the team decides that she's not going back. They're going to promote a safe passage to her. And the family brings me in just to see if there's anything we can do. And it turns out that this person was fine. Basically, she just missed to connect with the life and the world around her. So we have a beautiful video of her, where she comes back to life, literally, eating and talking and living, really. She was a completely different person. And this is what we call a third birth, when you have a person already on their way out, and then they realize that there's more life to live, and they all of a sudden they get this breakthrough and they become very good. I've had the other case of a gentleman who had a heart attack, of a massive heart attack, OR, ICU, and then he started to go into post-op delirium, all the restraints and all the drugs. And when we intervened, this guy was so lucid, so capable of coming back to life, and explaining how things went. And I was thinking, like, if we hadn't arrived at that time, I think this guy would be dead by now. And I'm not exaggerating at all. It's just that he took the wrong path, and he just was very unfortunate to meet the wrong people along the way. And poor assessment leads to poor diagnosis, and poor diagnosis leads to poor intervention, and poor intervention leads to premature death. And these sometimes are JCI accredited hospitals. Okay, so patient safety comes first, I understand, but where's life in it? I sometimes struggle to see it. Another young guy who had a motorbike accident, with the head trauma and all the neurological consequences of that, where we managed to understand that he was still there, he was still responding, because the way I found out is that he had a very weird name, and I asked him if I could call him by the short version, and he said no. He just did no. Like, okay, so he's alive, all right. And so basically, yeah, we picked up this guy. We made him walk. He walked quite a distance. It was amazing. Everybody was super amazed by the results. And then on that same day, later on, I saw the physio working with that guy, and I saw that the physio was doing everything for him and not engaging at all with him. And so I went in and tell her, like, hey, listen, if you ask him, he does this, he does that. You just talk to him. And after a while, she just responded to me very, very harshly, saying, "I know what I'm doing." I was like, okay, clearly not, but I'm not the one to tell her, right? Who am I to go and teach a colleague how to get better results from a discipline that is not even mine? So yeah, so obviously we do have a lot of these results where we see that there's a lot of hope, there's a lot of life to live, but because of poor assessment, it leads to poor intervention. In I tell many times when we ask for these cases where we do case studies, I ask for the basic information, the clinical records and whatnot, but by now I dismiss most of them. I know that this once again sounds very arrogant, but I know that comes from a place of misjudgment. We are designed for acute care. The faster you decide, the faster you get done with it, the more survival rate. And when it comes to long term, when it comes to chronic, it's not the case. It's in the in betweens. It's between the lines that lies the truth. But you've read the book diagonally, but I want to read the book. So when I go in, okay, sure, you can tell me the synopsis of the story, but I want to know the the story.
Yeah.
And it's when you find out the story that you kind of come across amazing people. This one lady who lived 13 years in a basement in the room that was the size of her bed, without even a window looking outside, who was alive. So it's people that when you connect with and you realize, wow, so human beings are incredible. They have an amazing survival story, but sometimes healthcare is not available to accommodate these human beings. And because of that, we fail to identify potential, and we fail to bring hope, and we fail to address their real needs and bring them back to life. Yeah, people.
Yeah, and I think I'm really curious about because you have a very sensorial type of approach from what you described, and I was wondering if for elderly people who actually many of those are have sensorial impairments in some way, like hearing impairments, visual impairments, in which the world might kind of be dimmed down, and I wonder if your type of intervention with lots of the appropriate sensorial stimulation kind of brings them back to life because of that.
Actually, the Japanese helped us to understand what's going on. So it turns out that our brain is a machine. Well, it's not a machine, it's a survival organ. Sometimes that's a mistake we make. It's a survival organ that is more interested in protecting our own well-being rather than anything else. That's why we lie to ourselves, and that's why we that's why we don't accept sometimes some factual evidence, because it kind of hurts us. But anyway, so as a survival organ, it's designed to do what? To receive input, process it, and decide what to do, formulate a response or an output. The quality of the input compromises the quality of the output. So if I don't have proper input, my output will always be conditioned. So if I don't have good information, my response will be limited. But what we see is that the brain can have problems in all these matters, in the quality of the input, and the quality of the processing, and then the quality of the output. The Japanese figured out that when we use the Humanitude approach, we actually improve the quality of the input, and we improve the triggering of the certain elements of the brain that are considered or deemed fundamental for proper decision making. So by now, with the encephalograms that they've done and with the neurological studies that they've done, it's pretty evidence-based by now. Before, we didn't really know, but by now, if you want, I can give you some of the articles. They're a bit over the top, but so but it's interesting to see that you have fundamental structures of the brain that operate much better with the right with a positive input, and therefore the output is going to be naturally better, just because you improved on the input. So yeah, we could say that this is just a miracle, or this is just a coincidence, or this is just because it's a good day outside. No, it's basic neuroscience. We didn't have access to this up until, I want to say, 20 years ago. But but by now, I mean, 20 years is a long time in science, right?
Yeah.
So by now we do have a lot of evidence to support that, yeah, that this sensorial approach is fundamental for a better health outcome, considering health a subjective well-being, as a subjective state of well-being. So yeah, it's not necessarily just a blood test. Okay, so maybe your blood tests are going to
Yeah.
be the same, but you're going to feel much better,
Yeah.
and that sounds
And
good too, yeah.
it's very interesting because during my PhD, I was studying breathlessness at in palliative care, and one of the most interesting studies I read was actually in people with COPD, chronic obstructive pulmonary disease, and they were assessed for breathlessness, and they were assessed for really objective measures like lung function, etc. And breathlessness was actually a better predictor of mortality. So we tend to ignore the subjective information just because it's subjective, but sometimes it's actually very a much better indicator, even though we can't really, you can't really touch it. You can only listen to what the person is telling you. But yeah, it's super interesting, and I think it's much more relevant than people think.
But if you want to
So
bring neuroscience to it, you have parasympathetic systems, you have anxiety, you have the amygdala triggering for cortisol producing production. So in the end, you do have other physiological elements to
yeah,
that. Okay, it's breathing, yeah, but it does have a function, and it does have a brain underlying, which is altered by different aspects. So
yeah,
maybe just the C tactile fibers, the activation of that with the activation of the parasympathetic system is going to improve the the breathing pattern, and therefore it's going to have a better outcome. So yeah, so you did nothing. What you did was a positive tender touch, and altogether,
yeah,
yeah. And you know that to activate this, it's 2 to 3 to 10 centimeters of skin per second. So we can be as objective as this. Like I'm giving you this touch because I want to improve your breathing pattern, because I know that this is gonna have a better predictor in your mortality rate. And it's like,
right.
well, why are you touching people? Like, yeah, because I'm doing my job. So hey, yeah.
You couldn't say that during COVID, though.
No, during COVID, you use protective equipment. You touch people just the same. And you can't survive healthcare without using your hands. That's the thing. There's no Jedi powers yet. So maybe one day.
Yeah, no, absolutely. And it was a big concern during COVID, that the fact that people couldn't be closer.
Yeah,
Um,
I worked through COVID with all the PEs, and the results were just the same. People are
yeah,
people, of course. More obstacles to the relationship, but still work just the same.
yeah.
Yeah.
Awesome. João, we're coming to the end of our time together, but I really wanted to ask one last question, which is there anything that you'd like to touch on that I didn't, or any message that you would like to leave us with?
Yeah, I've been telling you in more private matter. I think what we're doing here is fundamental to push the boundaries of healthcare. I think we need to be a bit more open-minded about the body as a whole, and please bring more people who can give us perspective. And I think there's a lot of evidence in other sciences that can add on to this. So we can go into physics if you want, or if you or even sports or whatever. Just to give the idea that we're not just an isolated discipline in this spectrum. And yeah, of course, to bring the discussion of end of life and the discussion of dependency, I think it's important.
Right.
And thank you for bringing the discussion of care refusal. I think it is a very, very important topic that no one is still, I mean, I can't say no one, but very few people are still being concerned with. And I think there's a huge opportunity there to improve our health outcomes. They will never be 100%. I say this as well. Whenever in health we say 0 or 100, someone's lying.
Yeah.
So, definitely we can improve the health outcomes of people going through, I mean, whatever end of life, chronic degenerative diseases, whatever you want to put yourself into this. But I think we have a lot to do still in healthcare. And yeah, the truth is out there. It's
Oh,
X5.
yeah.
Bit silly.
Yes, absolutely. The truth is still out there, and we need more people working in this area.
Yeah, yeah.
So thank you so much, João. It was such a pleasure. And thank you all for listening. And we'll see you in another episodes later.